welcome back to the little project we like to call Lary Talk, the podcast that is for laryngectomees, hosted by a laryngectomy. I am your host with no throat, but a very sexy voice. I'm Henry King. How you guys been, man? I hope you had a good Tuesday. Tuesday. On my Tuesday, I got to spend the time interviewing Dr. Fontanarosa, or a laryngologist out of Western New York, who will go over today all things that is all about laryngectomy, where he sees it going in the future and some of the advancements that's actually taking place, and a little bit of his personal life, but mostly about his profession. And yeah, it's going to be a good episode. Episode 10, everybody. Give it a round of applause. 10 episodes. I mean, it's not much, but whatever, for a bootleg guy with no voice doing it from his kitchen, giving you some information about a subject that not many people know about. Not goddamn bad, if you ask me. And this episode's a full circle because Dr. Fontanarosa also did my surgery. So he was my personal doctor. No bias there. He's just an intelligent guy, and I thought he'd be great for this podcast. And before we get into all that, let's do the normal thing that we do, shall we? Go look up Aaron Wayne, contact him at the email here below, and get this book, The Silent Partner, My First Year as a Laryngectomy. This is Aaron Wayne's take on becoming a laryngectomy. It's a lighthearted, it's informative. There's nothing in there that's going to scare you. It's a good read. It's funny at moments. And I think you should get the book because it's a pretty goddamn good book. Anyway, if you contact Aaron, he also might send you some stickers to decorate your HME with. The one I'm wearing this week is the Lary Talk logo, which you might be able to see it a little bit better. I got a halo ring light, whatever you want to call them, for Valentine's Day for my wife. So I'm moving up in the world, getting professional, kind of. And speaking of moving up in the world, Lary Talk is now on TikTok. I know, weird, right? I figured whatever format I can get out there with to draw people in, I'm going to use it. So if you go on to TikTok and you look up Lary Talk Doc, I know, it's kind of thing, right? You'll be able to find me, and it'll be like tips, stuff like that. You can ask questions, and also some of my humor, which is, out there. You might like it, you might not. But either way, as long as it brings people in the ear and it raises awareness for laryngeal cancer, I'm good. So, Lary Talk. And if you type in a hashtag Lary Talk, I should come up with throat cancer, cancer awareness, laryngeal cancer, laryngectomy. You type in any of those hashtags and I'll come up. So, on to this week's episode. I'm going to keep my portion short because I think the interview is more important than me talking. You know what I mean? So my portion, I'm just going to go over, if you're here right now, you're obviously on the fence about getting a laryngectomy, or maybe you're just here to learn. Either way, this will be good for you. If you're about to go in for your surgery, this is another good one to watch. So that way you'll kind of know what to expect. Although, if you're about to go in, if your doctor's good, you should know what to expect. But the first thing I'm going to suggest to you, man, I can't stress it enough, is some kind of support group. If it's not in person, at least online. Sorry about that. Find another Lary, somebody that's gone through this, not a Lary that's new to this either, like a Lary that's done it for a while, you know what I mean? At least a couple years into it, at least, I would think. So that way, you got somebody to talk to, and you can not only talk about the bad, but the good, So it's always good to have a support group. It's always good to talk to somebody that's been through it. So that way you get their perspective, because the doctor can tell you, he can give you all of it up front, tell you what's going to go on. You don't really get the idea until you talk to somebody, see somebody. And even then, you're not really going to get the idea until it happens. That's the sad fact of it. There's no training manual for this. You just go. So, but if you're getting ready to go in for your surgery, the hospital is going to make you sign some paperwork. And one of those is they're not responsible for your stuff. So if you're able to bring somebody, like I went in during 2020, so I didn't have any visitors. So I was able to bring my phone with me. But even then, that's a little tricky to do. But if you have somebody going with you, don't bring your phone, your laptop, and all that stuff. Let them bring it in after the surgery is done. So that way the hospital ain't got to keep track of this for you. That way there's no worry. So another thing I suggest is a week leading up to it, man. If you're able to eat all your favorite foods, whatever you like, eat it. Because it's going to be a minute before you eat normal again. It's going to be a couple months. And that's if everything goes well for you. And then, if everything goes well after the radiation portion, because that makes damage back there. And it's hard to swallow sometimes, Actually, most cases, like I said last episode, I only know one guy that went without a bed tube or a feeding tube of any kind during his radiation. And again, pulse. But I do suggest you take a change of clothes with you. Not like, jeans and a t-shirt and all that good stuff. You don't even need a shirt, really. But I do suggest some sweatpants, unless you like just wearing a gown. If that's your thing, then, I guess enjoy it. Let the butt hang out and do what it's got to do. But me personally, I want to be comfortable. So I brought a pair of sweatpants with me. Now, they give you those little socks in the hospital, so you ain't really got to worry about slippers or whatever. And they got grip. I like those. Actually, I wanted to take a bunch home with me, but I did take a couple. But, I don't know if you're allowed to take those or not. I think you are. They throw them out, right? They open them when you get them. So I imagine they just throw them out one-time use. Oh. The other thing, before you go into your surgery, make sure you contact your insurance company and have somebody that's going to be your voice. You know what I mean? Again, you're not going to have a voice when you come out, and this thing is not going to work well for you. First of all, you got to learn how to use it. Second, you got to wait for the swelling to go down for it to even be used. You know what I mean? When you're first swelled up, man, you can't find a spot to go to. It's all just, it sucks. So you end up sounding like, and yeah, you don't want that. So call up your insurance companies beforehand, if you got a spouse or a caretaker of some kind, and set it up so they can actually talk for you. You know what I mean? It will save you a bunch of time. I kind of wish somebody would have told me that, because that's probably going to be a whole episode, just insurance, It's a pain in the ass, especially if you got a state insurance, and I think all insurance sucks. But definitely do that. Get a hold of your insurance company and make sure you got it all set up for when you're out, because you're not going to have a voice. And they always want to verify. I need to speak to so-and-so. And it's like, dude, you really want to hear me? And also, you're going to be told not to eat or drink, usually after midnight. Usually it's about 6 to 8 hours before, 12 hours, I think, sometimes before your surgeries. They don't want you to eat or drink. That's for anesthesia reasons. There's a possibility, you choking and getting pneumonia and stuff like that. So there's things that can go wrong. So just listen to the doctor. They didn't go to college and do everything they did, all that medical training, for you to come in and think you know better with your GED. I mean, calm down. Listen to your doctor. Do what they tell you to do, so that way everything goes by smoothly for you. That's what you want. Don't make it harder on yourself. The other thing is, I know mentally right now you're just fucked right now mentally. I know. But try getting a positive attitude about it, because if you go in with a negative attitude, you're going to have a negative outcome. You got to go in knowing, I'm going to come out of this. I'm going to live, first of all. And then I'm just going to figure out how I'm going to live life after that. Let all those worries go. Okay. I know it's hard. I get it. Totally understand. But you can't dwell. You got to go and look at the positive on things. Because if you go in there, I'm telling you, if you go in with a bad attitude, bad outcomes. And I think that's the way it is with everything in life, man. If you go in with a bad attitude, you're going to have a bad outcome. Go in with positivities. Know this doctor is going to save your life. Know you get to spend time with your family, watch your kids grow, watch your grandkids grow, or be born, or whatever. You're going to live. Be happy about that. Focused on that. You know. Now, if you really want to know more about like my journey through the actual surgery portion of it, it was actually pretty funny, like losing my phone and having to go back to get it to find out that it was in the car the entire time, but it fell between the seats. That's a good time. 5 a.m, that's fun. You know, so if you want to hear that kind of stuff, that's episode 1. Going to episode 1. It's called My Journey Becoming a Larry. And yeah, you'll hear my take on what it took, you know, what I went through and before and after, what I dealt with, my mental state, all that. It's a pretty long one. I think it's like an hour and a half, but it's kind of entertaining, right? So yeah, so if you want to know more about my personal experience on that, check out episode 1. This episode, we're going to be talking with Dr. Fontanarosa. We're going to be talking about the future of laryngectomy procedures. And so you guys know, an otolaryngologist doesn't just do these. Like if he just did laryngectomy surgeries and that's it, he'd be broke, you know, unless he was the only one going around doing them, you know, like him and a team of like 10 guys, which, whatever. So the other things that an otolaryngologist does is like, anything that has to do with cancer in the ear, nose, throat, base of skull. So like no brain tumors, you know, nothing like that, but any kind of like sinus, your tongue, you know, your ear, that kind of stuff, you know. So I say, without further ado, we just get to this interview and get it over with, shall we? Because that's what you're here for. You're not here for this. You're here for the interview. So without further ado, the Lary Talk exclusive. Welcome back to a Lary Talk exclusive, folks. I am here with Dr. Joel Fontanarosa, who works in Western New York, who is an otolaryngologist. Doctor, how are you doing today?
I'm great. Thank you for having me.
Thanks for joining us. Take a time out of your busy schedule.
Of course, it's an honor.
So let's get right to it, shall we? Where are you from?
I am from Chicago.
Chicago. So you're obviously a Bears fan.
I am very much a Bears fan, for better or worse.
Are you open to Aaron Rodgers doesn't come back?
We have suffered a lot as Bears fans at the hands of Aaron Rodgers.
For sure.
He's a great quarterback, but yeah, no, I'm still very much rooting for the Bears. They're going to win the division this year.
You guys owe money. Okay, so where did you go to school? And how many years did you spend total with all your fellowships?
I was lucky to train for much of my education and residency training in Chicago. I was at the University of Chicago, University of Illinois in Chicago, and then Northwestern for residency before moving to Boston at the Mass Eye and Ear Infirmary where I did fellowship. And so quite a few years in Chicago.
And what made you want to get into medicine?
I was always interested in science and got exposed to some research at the hospital at University of Chicago and ultimately just fell in love with research. And some of my mentors in the clinical department recommended that I consider an MD PhD. And I really sort of fell in love with just the combination of trying to understand human biology and trying to understand it to improve human health.
Great. And what is the most challenging about your job?
It is just difficult to interface with people at the time in their lives where they're dealing with cancer. It's really a privilege to be able to do that as a doctor, but it makes for some just really tough decisions. And obviously, cancer is a phenomenon within biology that we struggle to control and understand. And that's just what all of cancer research is about, is trying to really do better with respect to both medical and surgical management of different cancers. It's exciting, but ultimately it's challenging to be patient facing in the face of some of these cancers that really have survival rates that are sobering.
And, what would you say is the most rewarding, which is pretty much an easy answer, but
Yeah, once again, it's just such a privilege to be able to do this kind of work and to really help people. It sounds very hokey and something that I think most doctors will say, but the actual practice of doing it is profoundly rewarding.
and what would you say is your biggest achievement in life and career?
Uh, I was very lucky to meet my wife as part of my career. We met in training, and we have a beautiful son, and it's just nothing is better than that.
All right, now let's get on to your actual career, what you do for a living. You're an otolaryngologist, which deals with the removal or the surgery removal of diseases from the ear, nose, throat, and the base of the skull. Most people tuning into this know the laryngectomy procedure, but what are the other surgeries that you perform in this field? And do you use robotics in any way?
Sure. So I operate all through the head and neck, anything that's not in the spine or the brain. We deal with tumors of the salivary gland, both benign and malignant. We deal with different types of thyroid disorders and cancers, lesions in the upper air digestive tract, the tongue, the back of the throat, the tonsils. Any tumors that spread to the lymph nodes of the neck we're generally involved with. And I also spend a fairly considerable portion of my effort doing reconstructive surgery. And so we do both regional and free tissue transfers where we're trying to design reconstructive options to maximize patients' function after losing something to different types of cancer. And those can range from relatively small procedures to surgeries that last most of the day. And sorry, the robotics question. Certainly, we use the robots to obtain access to different areas. We use that mostly for tumors in the back of the throat, the oropharyngeal cancers, cancers of the tonsils. Those are areas where the robot really does provide for better visualization and access. And that's something that most of us in head and neck surgery use. In laryngeal cancer, I do prefer using the robot for early stage laryngeal cancers. For patients with good access, it can really help get good clearance of margins. In fact, there's some recent data that suggests that the robotic approaches may do better than some of the more traditional transoral laser approaches. And so the robot really is a tool that most surgeons in my generation of training really are applying with good effect.
And they said playing video games would never work out for anybody, right?
My mom actually, when she found out I was doing robotic surgery, she commented that the time in video games probably helped.
Okay.
In all seriousness, no, it really is a very useful tool, and it is sort of the world's most dangerous video game.
Right. I can actually see in the future, like most surgeries being done with robotics of some kind.
It's interesting to see sort of how this has taken off and where it has. There's really been some just remarkable advances, and I've been lucky to work with just some amazing robotic surgeons who have stretched the limits of the robot, and it's great to work with surgical innovators like that.
Okay, can you explain the surgery and how long it normally takes, and what is the difference between a partial laryngectomy and a full laryngectomy?
Sure. So partial laryngectomy is generally for earlier stage tumors. And if we were doing that, there's usually a pretty good reason. I do look for tumors that can be resected cleanly with sort of while preserving the larynx. These are generally tumors that are small and away from areas that would lead to compromised function of the voice box. Partial laryngectomies are sometimes technically more challenging than total laryngectomies. But the decision for that is really a very case-by-case basis. But I do look for tumors that can be excised to try to spare some of the effects of radiation where we can. Those are obviously just have to be a case-by-case basis based on the anatomy of the tumor. And then so the total laryngectomy, I think it's a pretty routine procedure. It is, of course, drastic. It's just the removal of the entirety of a beautiful organ that we can't really yet replace. The total laryngectomy is a fairly simple procedure. I do generally book these cases for most of the day. It takes anywhere between 4 and 8 hours, kind of depending on the quality of the tissue, whether or not there's been radiation in the past, the extent of the tumor, et cetera. The need for reconstruction can also determine the length of surgery. If you need a free flap to help with some of the reconstruction for any number of reasons, that will add just a little bit of length to the procedure.
When you're talking about the flap, that's where you take the muscle from usually the chest area, right?
Yeah, sometimes it really does depend on the indication. Most of us like pec flaps just because the tissue is right there. You can really use that muscle for good effect. Actually, one of my mentors at Northwestern, a guy named Gurjeet Patel, wrote a great series, or it was a multi-institutional trial, where they pooled a few hundred patients from around the country and looked at different reconstructive approaches that you would use for salvage laryngectomies after radiation. People who had laryngeal cancer come back after they've already had radiation for it. In that group of patients, the patients in the pec flap group did really well, as did the patients in the free flap group. But given the success of the pec flap and just the ease of use, most of us do prefer it, and it offers just a great amount of vascularized tissue that hasn't been radiated to help everything heal really well.
All right. And laryngectomy seem to be on a rise, and yet still a rare procedure. How do you learn this procedure? Do you practice on, say, a cadaver, an animal, or a dummy? Also, why is there so many different ways of doing this procedure? For example, I've seen surgeons use staples. I've seen others use stitches. The placing of the feeding tube can be different. The placing of the feeding or the drain tube can be different. Is it a teaching reason, or is there another reason?
Sure. So a lot in that question. So first of all, there are certainly cadaveric dissections that you do during medical school and more in residency, really, where you can get access just to the anatomy once you're already have seen a number of these cases. Throughout training, you assist throughout 5 years of training in otolaryngology, where you really see this procedure over and over. And then in fellowship, that's really intensive time where you're immersed in this field. In my case, I was very lucky to train with 5 amazing surgeons who did this operation just a little bit differently, and seeing those different approaches shapes your view of how everything works the best in your own hands. And so there's no, by the time you're doing it on your own, you already have a good sense of what you're doing, and you've been well trained in that. In terms of the specifics about suturing versus staples, there's some really interesting data out of Israel with the stapler. I admit I have not used the stapler. It's just something that hasn't really been a part of my training. I would be open to trying a case, but obviously just trying something new. I'm happy with the results that we have with the methods that I use, and those have been fine-tuned sort of by my mentors and are things that are really tried and true. And so I think the slight differences between these different approaches, whether or not you're doing a drain, whether or not you're doing a G-tube up front, those are all sometimes based on individual concerns. And for example, if somebody's losing a ton of weight before surgery, I want to make sure that their nutrition is the best it possibly can be before surgery. And so sometimes we'd have a G-tube placed beforehand. It's obviously a decision that we talk about and nobody really ever wants a feeding tube, but it's a necessary portion of recovering from laryngectomy.
Yeah, the feeding tubes do suck, but I got to say the NG tube coming out was the worst part of it. That guy
You're
should
not
have,
alone in that opinion.
yeah, he should have yelled "ta-da" when he was done. Like,
I promise we all don't like them, but they serve a necessary purpose.
okay, so I've noticed that everybody's each is different in regards to how the person can handle it and how the actual cancer is removed and stuff. How do you deal with this kind of challenge? Like, say with somebody that's not going in with the right headspace, I guess, is one way of putting it.
It's really tough. This is a really difficult operation to discuss with people just because it's so life-changing. The exact means by which we discuss this with patients, it does vary from place to place. I think it's best done in the setting where you have a whole team that's very experienced with this type of thing. In our center, we're lucky we have amazing speech and language pathologists who will sit down with patients for a whole hour and go through sort of the different things that we can do to optimize speech and swallowing function. I will talk with patients a lot about just the surgery, the recovery, what things are like step by step in the recovery. And ultimately, I try my best to help people understand that. I found that until you actually go through it, it's really difficult to know what it's going to be like. The thing that we offer that helps patients a ton is individual meetings with survivors. We have some volunteers who are remarkable people who are willing to talk with people one-on-one. I think that's the most helpful. Just we can talk about the operation, but talking with somebody who's actually been through it really helps a ton, helps a lot. I think this podcast is a good example of just familiarizing people with what somebody doing very well after laryngectomy can look like. And that helps more than anything. People are really getting good education on this by meeting other people and asking questions. Those people do the best.
Yeah, I do highly recommend a support group of some kind, because it helped me out a lot in just making my decision to finally get to surgery, let alone anything else after that. You can tell me every fact that you know about it, but until I hear it from somebody that's gone through it, lived with it more than like a couple of years, then Absolutely. I get it. Okay, let's see here. Where am I? Okay, so how many laryngectomy procedures do you do in a year? And has it been more or less than the average in recent years?
Sure. So, I mean, this varies from center to center. For me, I actually looked this up after getting the question. And it's, somewhere between 2 and 3 a month. Typically it does. Obviously it depends on who I end up meeting in clinic. And I'm not the only one performing laryngectomies here at University of Rochester. I have 3 other colleagues who are also doing them. But, approximately 20 to 30 a year would be fairly typical for a head and neck surgeon at an academic practice like me. Some of the busier centers, people are doing, far more than that. And obviously there's some people who do far fewer.
Right. And these bigger centers are going to be in the bigger cities like New York City and Houston.
Yeah, and there's
like
some
Los Angeles,
major referral centers that that really get people, and some places that are centers for clinical trials. I think our center at Wilmot and Rochester, we do I think a very good job, as do some of the other regional hospitals.
Okay, so many people choose the radiation and chemotherapy over laryngectomy procedure. I was almost one of them. What is the pros and cons of going that route? And when is radiation and chemotherapy no longer an option?
So this is something that, again, the centers that have a good multidisciplinary team do better with, because the decision to preserve the larynx is something that people have talked about for decades at this point. There was a study in the early 90s through the VA where they showed that it was safe to preserve the larynx with primary treatment with chemoradiation. What that trial showed, and what others have solidified, is that for tumors that are large, that extend through the cartilage, that are involved in the soft tissues, there's a very clear survival benefit to doing an upfront laryngectomy followed by radiation. That's not controversial, and survival rates have been shown to improve for populations that are treated with more surgery. The decision for laryngectomy also depends on how well the larynx is functioning, and so the head and neck surgeon should be looking at how things are working in the larynx at the time of diagnosis. And if there's evidence of significant vocal fold immobility, if there's evidence that somebody's not really swallowing that well, or somebody's losing a ton of weight, or aspirating, all those problems tend to only worsen with radiation, and those patients have a higher likelihood of going on to need a laryngectomy for non-functional larynx, which is just a key thing that we treat. I do several laryngectomies every single year, where it's just not for any cancer, but for voice box that doesn't work well after chemotherapy and radiation. The most important thing, though, is that for these large tumors, survival is improved with total laryngectomy. And that's why I think people like yourself who are coming in for recommendations will get the recommendation for an upfront laryngectomy, and that ultimately saves lives by improving our control of these more aggressive cancers.
Okay, we know tobacco and alcohol is links to cancer. HPV is a controversial one, but with smoking at an all-time national low, and there's an HPV vaccine now, what are some of the other reasons to be getting a laryngeal cancer? I know some that never smoked, never drank, and some are even children.
So the smoking is by far the big one. Smoking is has been shown time and time again to be the strongest risk factor for laryngeal cancer, and so that needs to be front and center. Laryngeal rates of laryngeal cancer have gone down because smoking rates have improved. Survivorship after diagnosis with laryngeal cancer is significantly improved with smoking cessation. And again, just talking about the multidisciplinary team, having somebody work with you to help quit smoking is a key part of cancer treatment and is something that most cancer centers offer. The HPV is controversial. That has been shown to be clearly linked with different types of cancers in the head and neck, like the tonsil cancer, cancers from the base of the tongue, and it's associated with better outcomes. For laryngeal cancer, there have been groups that have described laryngeal cancers that are associated with different HPV subsites. The group at Hopkins described one a couple of years ago, and there is some limited evidence that shows that HPV-related laryngeal cancers have better survival. Other factors, alcohol has been shown to be a key factor. Other environmental exposures have been trickier. Things like air pollution, occupational chemicals, things like this have been looked into, and there's some good sort of population-based data in support of that, but that evidence isn't quite as good. And so those of us working on this really focus on smoking and alcohol, since it's a big enough risk factor that we definitely know about and can help control.
So do you think with us wearing masks, well, the ones that did anyway, wear masks for 2 years, do you think that that's going to actually help things go down a little bit?
We'll see. Time will tell. I'll look forward to seeing the data.
Okay, let's see. Let's talk recovery for a minute. Recovery is probably the most difficult part of getting a laryngectomy, both emotionally and physically. What are your recommendations to help not only heal quickly, but to heal properly? We obviously know finding some kind of support group of some kind is one way, but what's the other ways, like physically, to help yourself heal better?
Yeah, absolutely. Support group. And that goes back just to the other difficult part of just realizing that you need it besides recovery. The big thing that I focus on is nutrition. I think that really is something that laryngeal cancer can oftentimes affect the swallow in really profound and severe ways. Addressing nutrition in advance of surgery can really help mitigate some of the complications. The other things are just sort of basic labs, making sure that we're watching out for comorbidities with the population of laryngectomies. Many people who need this surgery are people who've been smoking for decades, and they have health consequences as a result. And so I'll oftentimes work with anesthesia to make sure that we go through kind of what they call a prehabilitation, where we'll make sure that all the different medical problems are buffed as much as we can to get those in control, anticipation of a multi-hour surgery. Other things, we're recognizing issues with thyroid function and other things that can happen after radiation for salvage patients. We pay pretty close attention to that at our center, and there's a multitude of things that we do to prepare in terms of looking after the medical side of things. The psychological part is equally important, and getting people prepared with support groups shouldn't be underestimated. That's something that really helps.
I see a lot of Larrys that could assume they no longer can do the things they were doing before. I've seen videos of Larry swimming, hiking, flying, exercising. I've known some of them that went right back to work after surgery. And some of them are even at a sawmill, believe it or not. And it's like nothing had ever happened. What are some of the success stories, so to speak, that you've seen some people do after surgery?
Yeah, this is where I'm just constantly impressed by uh, human beings. It is remarkable what people can do in the face of just this severely altered anatomy. I've had people go snorkeling. I've had people play the trombone. I had a guy run a marathon. It is amazing how well people can do functionally after this. And I mean, as you mentioned, sometimes people are walking around, you would barely know they had a laryngectomy.
The only reason why people know is like this right here. That's it. Other than that, if I was just to do my normal talking, they think I just got a bad throat. That's all.
No, and you're obviously just doing remarkably well with the podcast and everything else. Is why I'm so
Right.
excited to be on.
Like I can even yell, kind of, but I've been trying to work on doing voices, but that's not working out too well. Okay, let's see. So I've seen many Larrys wonder why they haven't made an artificial larynx yet or a transplant of some kind. Can you explain why it's such a challenge and if they even have that kind of technology at the moment?
Sure. So this is one of the coolest areas of research in my field is the people working on both artificial implantable larynx kind of devices and also the people who are designing scaffolds for this. Transplants have been done and there's only been a handful, and I think people are still working on organizing trials for that type of thing. There are some issues with designing these things and putting them into practice, not the least of which is just the unfortunately sobering rate of cancer recurrence that can happen despite aggressive surgery and radiation. And so designing these trials with an eye towards maintaining survival rates and not obscuring a cancer recurrence, it just requires some finesse. And most of the larynx transplants that have been on patients who didn't necessarily have laryngeal cancer. But actually, I do have some pictures that I pulled up that I thought your audience would like.
Oh yeah, share away. Yeah, the one video I watched of a guy had a transplant. He didn't have laryngeal cancer. He was in a car accident.
Yeah,
and it crushed his voice box, and he had to,
And yeah, I think the one that was done in the late 90s in the Cleveland Clinic was actually taken out after a fairly long time. And then the one at UC Davis, I think there was evidence of reinnervation, but ultimately I think the function was still somewhat limited. But the surgeons who are organizing these trials are amazing. And it's just one of the most exciting areas that I think all of us are looking forward to being fleshed out. But yeah, if you can see my screen here, this is just a picture, and maybe you can post the video link to the New England Journal of Medicine that highlighted this. This is an example of, I think, in France is designing this, where they sort of organize this such that it could be put into somebody to create a functional voice, and they have a video up on this at the New England Journal of Medicine. The laryngeal transplants are just a subset of things. People are now designing these tissue scaffolds where they'll make a sort of 3D model of a larynx and they'll coat it with stem cells. And they've implanted these in dogs and pigs. They've even gotten the pigs to make noise, which is amazing. And this kind of work is the future that I think most of us are excited about. Still a lot of work to do with that. There are some people who are looking at these different types of tissue scaffolds, or I think even MedPOR modeling, things like alloplastic implants that can be designed for partial laryngectomies, where you can cover that with vascularized tissue. A guy named Rick Hayden and a guy named, I think, Lott out in Arizona are working on this. I'm looking forward to seeing the future of this, and it's something that really might not be that far away, but in terms of using it primarily for reconstruction at the time of cancer, I think we're a ways off on that. I think laryngectomy for cancer will be necessary for the near future. I can certainly imagine a future in which we just understand how to manage the biology of that cancer better. But until then, we're left with a pretty limited survival benefit. That is, these advanced stage laryngeal cancers have been shown on a national population level to have a significant recurrence rate that leads to decreases in survival. The SEER data published most recently show that a 5-year survival for laryngeal cancer is something like 60%. And that's just unacceptable. We can be doing better with the available tools. And so implementing best practices, I think, is critical for those of us in the American Head and Neck Society who are working on this.
So I'm 42 now, I'll be 43 in July. Do you think in my lifetime I'll see this procedure become a thing?
I do. I'm an optimist.
I'm not saying like I would get one. I'm just saying future people. You know what I mean?
Oh, honestly, you are remarkably young to have gone through this procedure. You are in the very fairly rare percentage of people who undergo this at such a young age. It does happen. I've certainly operated on others like yourself. But yes, with what I expect is a good survival rate for these younger laryngectomies who are getting good treatment. I happen to think that your survival rate is equal to somebody else once you pass that 5-year mark. There are obviously consequences of radiation and everything else, but for the next 5 or 6 decades, I'm looking forward to seeing what the future holds. It's really remarkable what research is doing. Aside from these cool and these new methods to seemingly derived from science fiction, where we do these tissue matrices with stem cells, we also have innovations in genomics where we're just learning how to tinker with that better. And so the notion of surgery for laryngeal cancer, I can definitely envision a future where we might not need to do as many total laryngectomies. And moreover, I think that the day will come where we can put a laryngeal transplant routinely into somebody who's been shown to be cancer-free. There's obviously just a lot of work that needs to be done before then.
Right. That's why I said my lifetime. That way you ain't got to be like 20 years. Yeah, whatever.
Oh no, I'm really optimistic about it. And some of this work has been done, and people have been writing about this for 40 plus years at this point. The first laryngeal transplant was in the late 60s. And understanding transplants better and how to make them function, it's just getting better and better. People are doing new things all the time. There's a guy in New York City who just did a tracheal transplant with good effect. Doing it for the larynx is slightly more complicated, but that's also been done. It just hasn't been shown to be effective in a large group of patients, and it's far from being routine at this point.
Right. Science amazes me, man. Okay, so we also see a lot of nurses and other doctors that have never seen laryngectomies and have no knowledge of what we are. The biggest problem is explaining the breathing through the stoma only. There's been incidents where oxygen's forced onto a Larry's face, and I realize we're rare and all that, but is the laryngectomy not really taught? And how can we fix this problem? Because it's frustrating when you got to explain to somebody in the medical field your medical condition.
Oh, and as a doc who has plenty of patients who are laryngectomies who come into the hospital for any number of reasons, yes, it is. We try our best to educate our colleagues. It's just it is a uncommon procedure, and so it's something that not a lot of doctors are familiar with, even though it is taught in medical schools. But it's the responsibility of people in otolaryngology to continue to educate those and other specialties about just some of the nuances for our patients. And yes, it's an objective. Just education of our colleagues is part of what we do.
Like I try to explain to other Larrys that like you might be the only Larry within 100-mile square radius, and they might have learned the procedure in like college, but that was 20 years ago. You know what I mean? So things get forgotten. Think how many math problems you forgot since 3rd grade.
Well, and I'll say that at academic places, at major cancer centers, you'll just run into that problem less because, there's a whole population of people that are being served by groups of docs who see a fair number of patients, and those patients then come back to our center for other things. And so there does tend to be just a better familiarity at academic medical centers.
Right.
and cancer centers.
Okay. When things go bad or good, how do you not take that home with you? Like if I had a bad day at work, something stupid of mine or minor, it didn't involve somebody's life, how as a doctor, are you able to not let that affect your everyday life?
This is a tough question, and this is one that honestly is really personal, just because it is a daily mission to try to do everything you possibly can in the face of some of these really advanced cancers, and just being systematic about doing every single step correctly, both in the OR and sort of around any aspect of patient care. It's really pretty easy to sleep well at night knowing that you're doing your best to kind of control factors that you're able to. It is tough though, just because of the biological enemy that we're dealing with in cancer. It is frightening how aggressive some of these cancers can be. And that's why I think those of us who manage aggressive advanced stage cancers in the head and neck, we really will be pretty upfront with you when at the time that we're diagnosing this cancer. And usually it does amount to a pretty straightforward and blunt discussion. And I think viewers of this podcast should be prepared for that. It's not our job to really mince words when it comes to just some of the just bad news that surrounds advanced stage larynx cancers. But yeah, in terms of taking it home, it's certainly a tough job. And once again, I consider it a privilege to be able to do what we do. It's just, I feel very lucky to be able to work with patients at this critical time. And again, I think for better or worse, we really do have good treatment outcomes by following the data, and just the mission to continue doing it better and better, to be part of research to do it better. That's sort of how most of us sleep well in the face of just some really grisly outcomes with the most advanced of these head and neck cancers.
Okay. And how much has changed in the laryngectomy world since you began schooling from now? And we covered where you see it going in the future, but how much has actually changed since you started?
So I think people have really adapted new methods to a number of different areas with this. I think the ability to reconstruct things effectively to minimize complication rates. I think a lot of the nuances of some of the technical things we do to reduce complication rates have really helped, just because laryngeal cancers and total laryngectomees have complication rates that some estimates show there's fistulas in 20 to 50% of people. That sort of infection and fistula rate can be unacceptably high, and there have been good studies on how to reduce that. And so I think piece by piece, people have gotten a little bit more finesse in the way that they make major decisions about how to do it. In terms of the technical aspect of removing the voice box, taking out the lymph nodes that are at risk, those methods have been stable for decades. And that's just based in our knowledge of the anatomy. We try to preserve as much of the functional anatomy as we possibly can while taking out anything that possibly could be cancer. And so those methods, I think, haven't changed for good reason.
Right. One of those, if it ain't broke, don't fix it.
Well, more just I think the understanding of anatomy and how to address it with surgery is, at the end of the day, a technical exercise of making sure that you're taking out the anatomy that's at the highest risk for being involved with laryngeal cancer. And I mentioned that just I'm lucky to work at a time after many hundreds of very brilliant surgeons have worked on this problem already. And so most of those problems have gotten worked out. Some in the early 1900s. It's really pretty remarkable how thoughtful and innovative doctors have been for all of the history of modern medicine.
I am so happy I don't have to go through surgery the way they did back then. Oh my God. I can't wait until we look at all the way we do cancer now and look at it as barbaric. You know what I mean? I'm waiting for the Star Trek life, I guess.
Yes, no, I think many surgeons, including myself, will be glad to have a day where we no longer need to do total laryngectomies, where we can have a more elegant way of addressing this problem That being said, I do think that we've gotten very good at maintaining excellent function in people after total laryngectomy. I'll say the quality of life for laryngectomies has gotten just so much better than it once was. And that's a testament to all of the effort by people doing research into how to just fine tune, okay, when do you put the TP in? How do you take care of it? What's the TP design like? How can we optimize swallowing function? What measurements should we be taking during surgery to make sure that we get the best swallowing function for this patient long term? What reconstruction should we be doing to make the swallowing better? I think all surgeons doing this operation now kind of ask these questions, and I think try to adjust the method of surgery to improve the quality of life, not just take out the cancer.
All right, so now I'm going to ask you the Lary top 5, the hardest questions of the day. What's your go-to, a burger or a pizza?
Pizza.
Pizza. And Chicago, it's always deep dish, right? What's your go-to ice cream?
Fish food, Ben and Jerry's.
What's the movie you've seen the most?
My wife watches Legally Blonde every single time it's on TV, which is a lot.
It's a good movie too. What's a better pet, cat or a dog?
With apologies to cat lovers, dogs.
Yeah, my wife's cat's a psycho, man. Wants you to pet her until you pet her, and then she wants to kill you. All right, and what's your favorite genre of music? And do you play music during the operation?
I like a wide variety of music, everything from jazz to hip hop to indie. In the operating room, yes, we do listen to music. I usually let the nursing team pick, and helps me keep track of what's new.
All right. Well, that's all the questions we have this week for you. I want to really thank you for taking time out of your day to come back and do this.
Well, thank you very, very much. I really appreciate it. It's an honor to be on.
All right, folks. All right, everybody. I'd like to thank Dr. Fontanarosa for taking time out of his very busy schedule to sit down with us and discuss this. And I'm actually optimistic for the future of laryngeal cancer now because of this interview, actually. Great guy. And I want to thank him for saving my life so that I could do this for you guys and show you all that it's not as bad as everybody makes it sound. It's not as bad as truth.com makes it sound. It sucks, but it's not bad. So with that said, we're going to exit this week. Join us next episode. And it won't be a month from now either. I'm actually going to get right on this one. But the next episode will be about communication. I just had my TEP change a couple weeks ago, my TEP. And the whole episode is going to be about communication after becoming a laryngectomy. We'll go over everything from boogie board to how my TEP works. And we'll even try it with this piece of shit. The most annoying thing in the world. So, Mr. Roboto. Anyway, we'll have fun with that. There's actually a TikTok video of me using this. It's got a lot of views on there. It's kind of funny. So again, check us out on TikTok. Get the book, The Silent Partner, My First Years of Laryngectomy. Aaron has also started a very, very smart group on Facebook. If you're a laryngectomy patient and you go to Lary Travel Group, you can find wherever you're traveling, hopefully, another Lary in that area in case something bad happens. Like, say they lose your luggage or something and you don't have any HMEs on you or whatever the reason. Maybe you just want to meet up with a Lary. This group will have people listed and they'll give you where they're at, maybe their phone number. And you can meet up and help each other out, get supplies, that kind of thing. I think it's a great thing. I think we need an app like that. Not only something that shows like other Larrys, but like cancer resource centers and cancer centers itself, stuff like that would ping up on a map. I think that'd be a great idea, but I'm just a simpleton. If you know how to do it, let me know. But again, if you're a Lary and you're traveling, go up and look up that group. It's a private group. You're gonna have to, you got to be a Lary to be in it. We're not giving out Airbnb to you mouth breathers. Anyway, So go check that out. If you go to LaryTalk.com, you'll find not only the latest episodes of Lary Talk, but you will also go to the help and support area, and you can find help and support wherever you are, whether you need it online or in your area. There's plenty of resources up there to click on. Just go and scroll through and see if there's something that can help you. And as always, there's the Lary Talk Facebook page and the Lary World group. You can go there. The Lary World group, you can talk about anything you want. Just keep out the politics and the religion, and we'll be good. And if you have some kind of cancer, magic elixir, you'll be banned. That's simple. We only go by science here, people. And go check us out on TikTok. It'll be fun. I'm just using that to draw people in the air. So if you actually came here from TikTok, let me know. It'd be kind of cool to find out. So until next time, everybody, take care of yourselves and have a good one.
Everybody wake up. It's a brand new day, and this is your chance to let your soul shine. Proud to be you and me, freaks and geeks. Always remember that your soul